I'm Dr. Jayashree. I'm an endocrinologist from Chennai, and I'm here to talk to you about the importance of using insulin in blood sugar control. We all know that the recent guidelines have talked about individualization of HbA1c. But for most people, we would try to aim for a HbA1c of between 7 to 8%. However, studies around the world have clearly shown that less than 1/3 of people achieve this glycemic target of between 7 to 8%. Studies, whether they are done in India or in other countries, particularly in Southeast Asia, show that nearly 60% of people do not achieve their HbA1c targets. And also, other studies have shown that by the time people get started on the most potent blood sugar lowering agent, which is insulin, the complication rate is close to 90%. So, why do we need to wait for complications to start insulin? The guidelines have clearly shown that once the HbA1c is above 8 and they're already on 2 agents and you're not achieving your target HbA1c, we do need to get started on insulin. The other important couple of things that we need to keep in mind, one is that when a person is diagnosed with diabetes, already it means that they've lost more than 50 to 80% of their beta cell function. The insulin resistance has started about 10 to 15 years earlier, but once the blood sugars actually start going up only when the beta cell function actually starts going down, which means already at diagnosis they have beta cell deficiency. For some people this gets reversed, but for a lot of people this is progressive. So it is important that we use insulin to help them achieve their glycemic targets. Insulin is beneficial in multiple ways. Not only does it help to get the blood sugars under control, and compared to all other oral agents, it is the most potent anti-hyperglycemic agent. There is no upper limit to the HbA1c reduction that you can achieve using insulin. Whereas with other oral agents, you might achieve a HbA1c reduction anywhere from 0.8 to 1.5 depending upon the baseline HbA1c. But with insulin, there is no upper limit. You can get it down even by 3, 4, 5%. The other advantage of insulin is that particularly when people are cachectic and they have a lot of osmotic symptoms, insulin is very beneficial. Insulin does not have any gastrointestinal side effects. It is very safe for the kidney. It is very safe for the liver. So in other ways also insulin is beneficial. And of course there are other touted benefits, like it's also an anti-inflammatory agent. So insulin has multiple benefits, but I think there is a complete underutilization of insulin because it is an injection. Once as physicians we get over the hesitancy to use insulin, and then we are able to convince people to take insulin because we are also convinced about it. Once we decide that we are going to start insulin, what do the guidelines say about the type of insulin we need to initiate? So whether we look at the ADA guidelines or the RSSDI guidelines or the IDF guidelines, pretty much all of the international guidelines recommend initiating with a basal insulin. And most of them say that we can start with 10 units a day. The currently available second generation basal insulins particularly help because they do not cause hypoglycemia. They have a duration of action which can be anywhere from 12 to 18 hours. They do not have a peak effect. So compared to the first generation basal insulin, which is NPH, the second generation basal insulins, particularly glargine among all of these, works very well in helping to control the fasting sugar. And because the fasting comes down, the postprandial sugars also come down. So if you look at the guidelines, they will generally say to start off with 10 units of insulin, usually at bedtime. However, if it is an elderly person and you're worried about causing a low blood sugar in the night, you can get started with insulin 10 units either at lunchtime or even at breakfast time and slowly adjust the dosage till the blood sugars come under control. There is this concept of metabolic memory. So the concept being that the longer that you live with higher blood sugars, the higher the chances of complications. And also it means that even when you get the blood sugars under control, these changes that have occurred are sometimes irreversible, which is why sometimes people get frustrated when, in spite of their efforts and the blood sugars coming under control, it looks like their kidney problem is progressing or their retinopathy is progressing or their heart problem is progressing. Why is this happening? It is because those changes that have occurred in the previous 15 to 20 years, you cannot reverse now suddenly just because you've got the sugars under control. So what does that mean? That we get the blood sugars to target as soon as possible after diagnosis of diabetes. Again, there was another beautifully done, elegant study which showed that a HbA1c which remained above 7 within 1 year after diagnosis of diabetes meant that these people were nearly 2/3 more likely to develop a microvascular complication at the end of 5 years. So The current recommendation is to get them to their target of less than 7 or 6.5 within 1 year of diagnosis of diabetes. If this means we have to use insulin, so be it. If we use insulin, get the sugars under control, we will be able to reduce the complications, get our patients to avoid complications and do the best by them. And in terms of initiation of insulin, like I said, there is nothing like basal insulin. I hope you found this little lecture on insulin useful, and looking forward to seeing you all again.